Okay. So, we are on to shoulder joint. So last class, you were supposed to watch the shoulder girdle video. And then this is our final PowerPoint. So if you have not watched the shoulder girdle video, you need to make sure you watch that, because after we finish this PowerPoint, you'll have your exam, which will be on shoulder girdle. So we won't finish this whole PowerPoint today because it's quite long, but we'll do kind of the part one of it. Who actually watched the shoulder girdle video? Okay. If not, you're going to need to watch it. So, bones for the shoulder joint are going to be kind of a combination of our shoulder girdle, which you know is going to be our scapula and our clavicle, so our shoulder blades and our collarbone, and our humerus. So basically our humerus to our scapula is going to be our kind of true shoulder joint. So if we're going to talk about the scapula, so a few of the things we need to talk about for the scapula should be a review from the shoulder girdle. But we're going to have quite a few fossas. Fossas are going to be kind of like shallow bowls. So we're going to have our glenoid fossa, which is going to be the lateral side. So you can see glenoid fossa right here. So when we look at our scapula, this is going to be pointed laterally. So if we look on the kind of terminal end of the lateral, we'll see this circle right here. So that circle, which is a nice kind of shallow groove, is going to be that glenoid fossa. And you can see our humerus is going to attach into that via our labrum. So that glenoid fossa is going to be this outer lateral. It's actually kind of like a pear shape. We're going to have our supraspinous, infraspinous, and subscapular fossas. So per the video last time, the spine of your scapula is going to be this ridge right here. So the supraspinous fossa is this whole area up above. So supra means above. So the area above the spine of the scapula is going to be the supraspinous fossa. The whole area below the spine of the scapula, so this whole area, is going to be infraspinous fossa. Infra means below. And then subscapular fossa is going to be the inside lining of it. So this whole inner portion that's touching the rib cage is that subscapular fossa. And sub means beneath. Okay. So next, so this one part shouldn't be reviewed. So the humerus, which is going to be our upper arm bone, so this is our humerus, is going to be very similar to the femur. So basically the humerus is synonymous with the femur. They're both very similar in that this is what connects to the girdle, and then we have two bones coming down, two bones, and then feet, hands. So they're very similar to each other, and their names are a little bit similar. So just like with the femur, we're going to have the head of the humerus. So the head of the humerus is going to be the rounded portion on top. I'm going to grab this arm. So we can see we have the rounded aspect up at the top of the humerus. So that will be the head. We're of course going to have a neck as well. We actually have two necks. We have a neck right below the head and a neck at the base where it starts to get wider. So we're going to have a greater tubercle and a lesser tubercle. So these are very similar to the greater and lesser trochanters of the femur. So the greater tubercle is going to be the bump on the lateral side. So we can see greater tubercle right here. If we look, this is a zoomed in view. We can see that rounded head, kind of the line of the neck. greater tubercle or tuberosity, I call it tubercle. It's going to be this bump on the lateral side. The lesser tubercle is going to be kind of dead front and center on the anterior side. So this is how you'll orientate yourself of if you know which direction you're looking at, right or left. You'll look for the greater tubercle on the lateral side, and then you want to look for the lesser tubercle, which is going to be the bump straight in the front, right here, on the anterior side. So if we don't see that big bump on the anterior side, then we know we're looking posteriorly. So lesser tubercle right in the center, greater tubercle on the lateral side. We're going to have an intertubicular groove, which is also known as our bicipital groove. So in between the tubercles, so greater to lesser, we have a kind of shallow area. Basically my pinky fits in it. So it's a nice groove in between the tubercles, hence intertubercular. Also, it's called our bicipital groove because our bicep muscle, we have a tendon that runs in between this groove and sits there. So the last thing on the humerus is going to be our deltoid tuberosity. So if you know, our deltoids are typically the kind of shoulder caps. You might have heard of those if you work out a lot. So the deltoid tuberosity is where the deltoid is going to insert onto. So we have this bump right on the lateral side, and that is our deltoid tuberosity. So it's not super prominent. You can see right here, deltoid tuberosity, about midway down the shaft of the humerus. Okay. So the shoulder is called the glenohumeral joint. That is the true name of the shoulder joint. So you can abbreviate it as GH. So gleno is glenoid fossa, humeral is obviously humerus. So just like the hip, it is a ball and socket joint. So it can do all directions, including circumduction. So with the shoulder, and what makes it different than the hip is a more stable joint. The shoulder has more mobility, but because it has more mobility, it lacks stability. So that's why you'll see a lot more shoulder injuries happening than hip injuries, because the hip is a more stable joint. So if you think, you can probably do a lot more movement with your shoulder than you can with your hip. So for movements, we're going to have flexion, which is going to be moving your arm all the way up above overhead, so flexion. Extension will be coming back down, and then hyperextension is technically going even further back. So flexion, extension, hyperextension. Oop. There we go. Abduction, very similar to the hips, coming up all the way up to the top. Adduction, coming down together. So external and internal rotation are similar to the hip in that you can do it quite a few different ways. So if we have our arm at abducted 90 degrees, external rotation, so kind of moving back to the external environment, internal rotation coming in. You can also do it kind of with your hands by your side, external rotation, internal rotation. You can do it with your elbows straight, internal rotation, external rotation. So you can do it quite a few ways. Look at the humerus instead of the hand. So the shoulder has a unique movement that none of the other joints have. And that is horizontal abduction and horizontal adduction. So horizontal abduction is basically in a transverse plane, so a horizontal plane, coming out this direction. So if we start with our hands perfectly in front of us, horizontal AB will be bringing them out, while horizontal AD will be bringing them in. So that is a unique movement to just the shoulder. Okay, so based off what I said in the last class as well, the shoulder, the true shoulder joint, the humerus, the glenoid, has to move in sync with the shoulder blade, the scapula. So as we start doing movements with this part, the scapula, does not stay stationary. It has to move with the humerus as well. So what we see in this picture is we have glenoid fossa to the head of the humerus. As we start to abduct the humerus, so bringing it up, you can see if the shoulder keeps moving, or the humerus keeps moving, you can see the acromion process of the scapula hits the humerus. So in order for that to clear, as your shoulder moves up, your scapula moves with it. So it has to do upward rotation in order to move. So if we have here, if we're coming up, this is our scapula. As we start to rotate, this starts to rotate with it in order to clear this bone. Because if the shoulder blade doesn't move, and I move my arm, I can't get past 90 degrees because I'm going to jam into that bone. So we can do a little test for this. So if you all put your arms out to the side with your palms facing down, are you able to go all the way straight up and touch the back of your hands together above your head? So you guys got nice bendy shoulders. Now do it with palms up and go all the way up. Which one's easier? Palms up, right? So when you do palm up, you're actually rotating the humerus out of the way so it can't hit the acromion process. So like I actually can't get my arms above my head if my palms are facing down, but above I can, because I have to rotate mine out of the way. You'll see some people have actually had a chunk of their acromion process removed, so they'll have much bendier shoulders and be able to do it. I can do it with one arm, but I have to really compensate. But if you try to get both, it doesn't work. Okay, let me see. Okay. I'm going to leave muscles for next time. So ligaments. We have lots of ligaments in the shoulder. Specifically, we're going to talk about 3. So we have our glenohumeral ligament, our coracohumeral ligament, and our coracoacromial ligament. So again, the easy thing with ligaments is their name tells you what they connect. So glenohumeral ligament is going to go from glenoid fossa of the scapula to humerus. So that's what this is, light blue, going from glenoid fossa of the scapula to the humerus. We're going to have our coracohumeral ligament. So again, make sure you watch that shoulder girdle video because some of these words are not going to make sense to you. So the coraco is referring to the coracoid process. So the coracoid process right here to the humerus. So coracoid to humerus. So this is that red one right there. Then we're going to have our coracoacromial, which is coracoid process to the acromion process. So that will be this yellow right here. So those are what's going to be kind of the true shoulder ligaments. And you can see we have a few other ligaments here that are more shoulder girdle ligaments that I've talked about in the other one. So just like the hip, the shoulder is going to have a labrum. So that labrum works as kind of a suction cup holding that head of the humerus in. So it sits right on top of that glenoid fossa because obviously we don't want just bone to bone. We need a little bit of squish in there to hold it in. And you can see that obviously it can get tears just like with the hip, and you'll have tears located anywhere throughout that require surgery, usually. Most people are probably going to have a labral tear. If you got an MRI of your body, probably everyone's going to have a small labral tear. It just depends on if it affects you or not. Okay, so some injuries we're going to talk about. The acromioclavicular separation, which is an AC joint sprain. We're going to talk about clavicle fractures, humerus fractures, shoulder dislocations, glenohumeral subluxations, and rotator cuff tears. Okay, so let's see. So an acromioclavicular separation is a separation between the acromion process of the scapula and the lateral end of the clavicle. So we know that the acromion process is this right here, sticking out. The clavicle, the lateral end. So we can see where they sit right next to each other. So this is held together by ligaments. So you have 3 types. So type 1, type 2, type 3 is just dependent on how bad the ligaments are torn. So you can see type 1, you have just a small amount torn. Type 2, you got a complete detachment of one of the ligaments. Type 3 is a complete separation, all the ligaments are torn. So this will result in a piano key sign. So if you've ever looked at someone who you can see right here, this would be a normal clavicle. Then you can see on this side, they have an abnormal clavicle. Their clavicle is sitting way up. So it's called a piano key sign because I could push on that clavicle, and when I let go, it would pop back up like a piano key. So you'll see this a lot more often in males, typically because they probably have played football growing up or more of a tackle sport. Women can still get them, but it's not as common. I'm not even sure what this video is. Sound, go away. So this is the AC joint tear kind of mechanism we often see. So we'll watch him, he'll have a playback. Eventually. So right here. So, it's not a very impressive mechanism of injury, right? Kind of just looks like he fell. So what happens a lot with AC joint tears, or separations, is, especially in football, is a much smaller person gets tackled by a much larger person. And what happens is they land on their shoulder, and then the larger person lands on top of them and squishes them like a little accordion. So with that, he was a much smaller player, went down, landed on his shoulder, a larger person fell on top of him, squished him, nowhere to go, so his AC joint popped open. So that's typically how you'll see AC joint sprains, or you'll have a Fouche mechanism, which I'll talk about next. So AC joint sprains and clavicle fractures kind of go hand in hand. If you suspect an AC joint sprain, you need to clear the person of a clavicle fracture. But a lot of upper extremity injuries occur due to a Fouche mechanism of injury. So Fouche is falling on an outstretched hand. So if you fall, your first instinct is to put your hand down to slow yourself. So that is a Fouche, fall on an outstretched hand. It's actually really bad, so never put your hand out to fall. You should always just tuck and roll because you'll break a lot of things, especially when you get older. Most elderly people break their wrists when they fall because they put their hand out to try to catch themselves. Break their wrist, break their hand, break their elbow, etc. So a lot of clavicle fractures can happen to falling on an outstretched hand, so that's fall with an arm out onto a hand. They can fall directly onto their shoulder, so falling straight down. You can also get that same kind of accordion effect, having a player fall on top of you, kind of crushing you. Or obviously a direct blow to the shoulder, so getting hit straight in the clavicle. So right here we can see a very broken clavicle. So this is quite a displaced fracture. The ends are not in line anymore. A lot of times clavicle fractures will pop out of the skin, so they'll become open fractures, or they will push so much you can see that the bone is going to poke out of the skin, but it hasn't poked out yet. Clavicle fractures are very dangerous, or can be dangerous, because directly underneath the clavicle, remember we talked about this with thoracic outlet syndrome, you have your subclavian artery, your subclavian vein. You have all of the nerves that supply your arm going directly underneath that clavicle. So if you have very sharp pieces of bone broken off, the bone can sever and rupture those arteries, those veins, those nerves, resulting in a lot of problems. So if someone has a severe clavicle fracture like this, the first thing would be to send them, so activate EMS, go to the doctor to make sure that they didn't lose their blood supply or nerves to their hand. So that's why if this was suspected, typically we would check their blood flow in their hand and we check their feeling. So humeral fractures are done very similarly, falling on an outstretched hand. Humeral fractures, they can happen in quite a few different ways. So these are all kind of the types of fractures. Spiral fractures typically happen due to someone pulling on something. So it happens a lot more in children because they're usually getting like yanked around following people. But the humerus is very hard to break. It's very difficult. It's a thick bone, very similar to like the femur. The femur is much stronger, but it's much thicker, so it's harder to break off. When I worked in a PT clinic for a little bit, I saw a lot of old ladies with humeral fractures because all of them fell while they were gardening. So they would fall, put their arm out, and break their humerus. So typically in a younger, healthy person, you're probably not going to break your humerus unless you're in a significant traumatic accident. Okay. Probably one of the most common and kind of aggressive injuries is going to be shoulder dislocations. Now, both the hip and the shoulder can dislocate, but the hip is much more stable. So you're typically going to have a very traumatic injury that would result in a hip dislocation. Versus a shoulder dislocation, remember we said the shoulder has more mobility than stability, they're going to be much more common to get shoulder dislocations. Typically, once you have one shoulder dislocation, you're going to continue having shoulder dislocations pretty much forever. You can do rehab to strengthen everything up, but it's never going to go back 100% the same. So with a dislocation is the bones coming completely out of their joint congruency. So we can have an anterior dislocation where the humeral head will slip anteriorly in front of the glenoid, so it will kind of pop all the way out. We can have a posterior dislocation where it will come posteriorly. You can also get an inferior dislocation where it will drop down. Will drop down underneath. So a shoulder subluxation is an incomplete dislocation. So if I have a full dislocation, I'm going to pop out and I'm going to stay out. This person will be stuck. They will not be able to move. A subluxation will be I start to come out and I pop back in. So I'm not fully out. So a lot of people, it's kind of a pet peeve of athletic trainers. They're like, oh, I dislocated my shoulder. They walk up to you like this. Like if you dislocated your shoulder, you would be stuck in the position that you dislocated. You would be unable to move it. If you felt it pop out and go back in, you probably had a little baby subluxation. So I've had a football player have a shoulder dislocation during a football game. Oftentimes, you get a dislocation in this position. Then they are stuck in this position. So we had a football player run out of the game like this, and people thought he was trying to high-five them. So they kept trying to high-five him, which he was actually not. He was dislocated and stuck. So you will literally be stuck until your athletic trainer or physical therapist doctor can reduce it. Let's see. Oh, yes. So this is a pretty good dislocation video. I mean, it looks like it's filmed on a potato, but yes. So the big part, so he's doing a snatch. So he's in his full kind of snatch position. His shoulders are actually completely flexed. He's kind of in an externally rotated position. The higher away you get from your body, the less stable you are. So if my shoulder is down here, I'm pretty stable. Once I get up here, I'm not stable anymore. That's why you have so much mobility. So you can see it pops out right there. And then, I wish this wasn't so like potato-ish. You can see his humeral head has completely popped out, and he's right there. Notice he is stuck. He is not moving. So he has dislocated it. There's no going in on its own. So they come, I love these little signs they put up. I wish I had these to cover up what they're doing. So he has dislocated his shoulder. See, my next one. Aw, man. Oh, this is a funny one. So another way you can dislocate your shoulder, which is a little bit more of a unique way, is you can fall completely outstretched. So if you are kind of sliding your arm, you can dislocate down. So maybe in volleyball, like if we're trying to pancake, or in baseball if you're diving for something. So even that mechanism can also result in a dislocation. But like I said, once you dislocate your shoulder once, you're going to dislocate it a lot. And typically, after the first few dislocations, it becomes much easier to put it back in. So if we have a person who's a fresh dislocation, their muscles are going to constrict really tight to protect it because they've never had that before. Once you're on your multiple dislocations, it slides in and out pretty easy. So again, he's stuck. He just dislocated. He's stuck. Now he is putting it back in himself because I'm quite sure he's done this a gazillion times. And all he's doing is applying some distraction and he's putting it back in because he's most likely done this a lot. So I do show you the slow-mo of it. So he dives completely outstretched and it pops out. And again, that classic, if you see someone going like this, you can automatically be like, oh yeah, they dislocated their shoulder. If someone runs up to you like this, you know they probably hurt their AC joint or their clavicle. Boom. And it's out. I'm sad the other one didn't work because it's actually a video of someone putting a shoulder dislocation back in. Okay, rotator cuff tears. You'll learn which of the muscles are your rotator cuff. But you hear this a lot. People are like, oh yeah, my rotator cuff's injured. It's another one of those injuries that people just like to say they have. But a rotator cuff injury is going to be any injury to one of the 4 rotator cuff muscles. So again, the rotator cuff, we'll learn it next time of what muscles it is. But it does all the external and internal rotation of the shoulder. You can get kind of tendinitis of your rotator cuff if you play rotation-heavy sports such as volleyball, softball, baseball. Okay, so that's it for today. We will do all of the muscles next time. I do want to show you, let's see, this will be posted like in 2 seconds. So neck trunk, shoulder girdle, extra credit assignment. So basically we have a drawing of everything you would possibly need to know. So you would label these based off of my PowerPoints. Don't be labeling them based off of the internet because then you'll have to put a lot more than what you thought. I'll show you. So I'll post this. So this will work as a good study way, and I'll have a submission. And then, because your exam 2 will be once we finish the shoulder joint video, then we will have a test. I have Jeopardies available as well. I'm kind of going to stop playing them in class because no one actually tries, so it's not very much fun to do. So I will post them for you to have, but I'm not going to play them anymore. Okay, you are free to go.